I welcome each and everyone who are wholeheartedly involving in the Plastiquest challenge for the last 5 years. I thank each and everyone. Our main aim is to make this as a pan-India teaching program for the plastic surgery preaches across the country. So everyone eagerly and enthusiastically, dynamically, whenever we invite, accepting and participating and sharing your knowledge. So it's my great pleasure to welcome the team Plastiquest. They are tremendously giving their support full time, and team APBC 2025 who extended their acceptance to conduct the online prelims prior to APBC 2025 and given the opportunity to the PGs to compete themselves and face the experts, stalwarts, and academic teachers of the country from all over the country, from north, west, east, south. And judges also, they are from all the corners of the country and readily accepted and sharing the gist and the knowledge in each session. And the panelists of the day and moderators of the all, they are known faculty of the Plastiquest and participated earlier also. I welcome each and everyone, and a few changes were made according to the feedbacks given by our seniors and well-wishers of the Plastiquest in the last session. That is reduce. We would like to stick to the time as all these topics were covered, well covered in the Nabicon along with the Nabicon Plastiquest. So we take these sessions as a real competitive sessions. So we should stick to time, exactly 30 minutes for the spotter. So number of spotters we reduced it to 3. And for each spotter, we allotted one panelist, one moderator, and one judge. So the judge will give the gist of the spotter, what to do, what not to do, and which is preferable procedure and all. And panelist and moderator will discuss, and other patrons and senior people also will ask questions to the both teams. And other teams also will ask questions, but they are divided for the 3 spotters so that the time will be restricted and we can complete in time. If we prolong, there is some negative T to our program. So we want to stick to the timings. Now I request Dr. Rohit to take the roll call and Dr. Rohit.
Oh, ma'am, I'm here. Okay, ma'am, I will take the roll calls. Team 1, BGMC Pune, are you there? Team 1, BGMC Pune. And Team 2, Sir Gangaram Hospital, PGs from Gangaram Hospital.
Yes, sir.
Okay, fine. Next, Team 3, PGs from BMC, Bangalore Medical
Yes, sir. Yes, sir.
And Team 4, PGs from Sage GS and KEM Mumbai.
Yes, sir.
Nice. And Team 5 and 6, you are there for this today's session, right?
Yes, sir. Yes, sir.
Next,
Yes, sir.
Team 7, PGs from
Yes,
AIMS Rishikesh.
Yes, sir.
Team 8, PGs from AIMS Bhubaneswar. Team 8, PGs from AIMS Bhubaneswar. Okay, Team 9, PGs from Southeastern Railway, Kolkata.
Present, sir.
Okay. Team 10, PGs from BMCRI.
Present, sir.
Team 11, PGs from KEM Mumbai.
Present, sir.
Team 12, PGs from Bhopal.
Present,
Excellent.
Present, sir.
Once again, last time, Team 8 from AIMS Bhubaneswar. And Team 1, BGMC Pune. Are you there? Okay, ma'am. Now we'll move to the session. I would like to welcome our 2 participants today. Team A is PGs from Jipmer Pondicherry, Shanmugh Priya and Kanav Gupta. And team B, we have PGs from SMS Jaipur, Dr. Sakshi Kashyap and Dr. Sriharsha Reddy. Ma'am, if you allow, I will move to the spotter one. I would like to request Sundarraj sir to start questions.
And
Sir.
moderator will be
Surajit Bhattacharya sir.
Surajit Bhattacharya sir, and
Right.
gist will be given by Dr. Vijay Joseph sir.
Questions will be to both the teams, madam.
Yes, sir. Alternatively, sir.
Sir, time is fixed 10 minutes. So you will ask alternate questions to alternate teams.
Okay.
And if one team doesn't answer, immediately it will be passed on to the second team. If they answer, the half marks will be given to them.
Okay, madam.
They say correctly, it is 2 marks.
Okay.
First question, team A, that is Jipmer
Yes.
Pondicherry.
You are seeing the picture here. Assuming
Yes.
the burns are confined to the lower limb, what do you think is the likely percentage of this burn?
This will come to around 25% burn, sir. Second degree deep.
I asked the percentage only.
But 25%, sir.
Okay. Question to the other team now.
Yes.
What is the likely depth of this burn?
Sir, this would be second degree deep burn, second to third degree, sir. You can see in formation of an scar, so I would say deep dermal burns.
How do you describe the appearance of the 3 degrees of burn?
Sir, for the first degree burns, just epidermal burns, it will be presence of just erythema. Then second degree is again partial and deep. Under partial, you would have formation of blisters. Under deep, you would have a wet, white, shiny appearance. In third degree burns, you would have a much more of a leathery and parchment appearance with thrombosed veins. Under fourth degree burns, you would have carbonization or gangrenous changes.
So you said second degree deep. Do you stick to that answer? Don't you see leathery areas in
It's a third degree burn, basically. It's a third degree burn.
burn? But if you say
With a leathery, waxy appearance.
Okay. Question to the team A now.
Yes, sir.
Sir, can we give the marks to them?
Yeah, I think so. They've answered.
Okay.
Yeah. Question to team A. What are Jackson's zone in burn injury?
So there are 3 zones of Jackson. The innermost is the zone of coagulation, then comes the zone of stasis and the zone of hyperemia.
What is the importance clinically?
Sir, the zone of coagulation is the dead necrotic zone where the blood vessels are not supplying, ischemia is there. Then comes the zone of stasis, which is between the coagulation and the hyperemia. And the hyperemia is the zone which is viable, tissue is viable, and only inflammation is there and will get better with the treatment.
Is it only to describe the burns, or is there any thing that this classification helps us or guides us to do with regards to resuscitation, proper resuscitation?
With the proper resuscitation, the zone of stasis can become normal. If the resuscitation is not done properly, it can get converted into zone of coagulation. The tissue becomes ischemic. So with proper resuscitation, the zone of stasis is it is interchangeable between coagulation and hyperemia.
Okay.
Sir,
Question to
you
the-
are asking so many questions. So marks, how you allot, you please tell to the Selvaraj
Also.
madam. Because almost 3 questions you asked to the team 1 only.
Okay.
So
No,
I have given only, I am assessing that as a 1 question now. Is it okay? Or do I put it as 3 questions?
So sir should ask the second team 3 questions, sir.
3 questions.
Yes.
Do you want me to give a mark as a single question or as 3 questions, sir?
3 questions because time is limited. So we
Okay,
have to,
I'll put it
yes.
as 3 questions.
Ah.
Okay, now 3 questions should go to team B.
Okay. Madam, do I mark the marks also?
Madam is marking. You just clarify him, sir.
Okay.
You just tell me whether it is right or wrong, or that's all.
Okay. Okay.
So full marks will be given to the team one.
Team
three.
one. So
Yeah.
4 questions have been finished for team A. So we need 3 more questions for team B.
Okay. Right. Team B. What is the immediate concern in this patient?
Team B.
So immediate concern will be on receiving the patient, we'll assess the airway, breathing, circulation of the patient. Since
Sir, on immediately, it looks like a circumferential wound. So I would like to do my immediate concern would be the formation of a compartment syndrome. I would rather focus on looking at whether I would need to do a fasciotomy or not.
What are the signs and symptoms you look for to say that there is compartment syndrome?
So first thing I would look is on palpation whether the limb is whether on touch it is feeling tense or not. Other things I would look for is the presence of pain on passive stretch, in the presence of pallor or the pulselessness present.
poikilothermia.
Okay. Is there any objective method to diagnose compartment syndrome?
So objective would be I would insert a needle into the by using needle I would insert into the muscle and measure the pressure using the saline volume expanded saline.
What pressure defines compartment syndrome?
So compartment syndrome would be more than 12 to 15 mmHg. Normal would be, the range is 12 to 15. Anything more than that would result in compartment, and more than 20 would be severe.
Okay, I think the books give the answer as 30 for that. What are the incisions that you will take? I mean, what is the procedure name that you will be doing?
Sir, I would go with the modified Henry's approach, and I would like to incise along the medial side of the starting from.
Are you going to do an eschorotomy or are you going to do a fasciotomy?
Sir, this looks like a circumferential wound, and since it's leathery appearance, a 3rd-degree burn, I would do a fasciotomy.
What is the difference between the two? Eschorotomy.
Sir, in case of eschorotomy, I would just be excising the eschar, and the underlying fascia over the muscle would be preserved.
The word correctly. Are you going to excise the eschar?
Yes, sir.
Excise or anything else?
So tangential excision, and if still the compartment is not released, I would go for release of the fascia also.
You are talking about eschorotomy. Is it incision or excision?
Eschorotomy is incision, sir.
I think we are done with the 4 questions.
Yes,
Yes,
sir.
sir. Now the question should go to
out of
team
4, 3 correct and 1 is wrong.
Yeah. Team A now.
Yes.
What are the principles of eschorotomy? 3 or 4 principles can you name?
Yes, sir. First is in eschorotomy, we'll go along the mid-axial lines. Then we have to incise such that the eschar is incised, and we reach till the.
And we should avoid any vital structures, injuring any vital structures.
Like what?
Like superficial veins or nerves, because
Okay.
we don't cross the fascia.
Okay. What happens to the joint when you reach the joint?
So there we have to give a curvilinear incision, so as there's not a straight incision, and
that doesn't lead to any contraction in future.
Okay. Question to team B. What would you do eschorotomy as early as possible, or will you stabilize this patient, post him to elective list and take to OT and do?
So as early as possible.
So does that mean you do in the emergency also?
Yes, sir.
Correct answer. Question to team A now. What is the significance of color-colored urine in this patient?
So color-colored urine tells us whether there is dehydration and if there is any damage to the underlying muscles because of compartment syndrome, sir.
And in case of electrical burns, it will signify about the muscle damage and myoglobin. In case.
Answer. Question to team B. If color-colored urine is there, what should you do?
So we'll start the patient with alkalinization of the urine, and we'll give mannitol to the patient.
You alkalinize, what is the first step?
Sorry, sir?
Before you alkalinize the urine, is there anything?
I would start my resuscitation with
Resuscitation.
7 ml per kg per hour, and then also add on soda bicarb and mannitol to the
Mannitol.
patient to alkalize the urine.
Okay, question back to team A. If you don't do this, what is the problem that will happen? If you don't increase the IV fluids, if you don't alkalinize, what will happen?
Sir, there will be damage to the renal tubules, sir, and the patient can go into acute kidney injury, renal shutdown.
Due to acute tubular necrosis. Okay.
Yes, sir, acute tubular necrosis.
Question to team B. So you have managed this patient initially. You have done the compartment release to manage the compartment syndrome. Resuscitation is adequate. What is the definitive plan for this patient?
Sir, my definitive plan would be, after adequate release, would be a tangential excision till I see a viable tissue and do a grafting of the involved limbs. And also at the same time, I would like to provide graft SSG to the penile and the scrotal skin as well.
Exposure dressing for the perineal region.
Just a minute. You said that this is third-degree burn, so tangential excision is not appropriate. Question to team A, what is the definitive treatment?
Sir, after fasciotomy is done, we'll put the patient in a elevation position, sir, and we'll have a second look to assess the viability of tissue after release. And based on that, we'll go for a debridement and then wait for the next stage, or we can, if the tissue is viable, then we can go for a stable skin covers.
After the excision.
So team answer tangential excision, which we didn't accept. What other forms of excisions are described
The
in?
facial excision is there, sir. Because this is deep burns, it is going up till the dermis. So we'll be excising, and the subcutaneous tissue. So we'll be excising till the subcutaneous tissue. And once the fascia is left, above that we can give a cover like grafting, sir. SSG.
What is the name of the procedure?
Facial excision.
Okay.
And also,
Question to team B. What do you mean by sequential excision?
So sequential excision is we are excising till the healthy bleeding subcutaneous fatty tissue is visible. Whereas in tangential excision, we excise it till the viable dermis is there.
So in sequence, we go one layer by layer. If the fascia is not viable, we go to the muscle. If muscle is not viable, we still go deeper. We reach the bleeding tissue.
It's
That
just
is generally what is meant by debridement, but sequential excision is what your partner said. It is suitable for a third-degree burn, where you go down to bleeding areas of fat, as against tangential excision, where you go down to dermis, where you see petechial bleeding. Question to
Sir, you will have to actually give the question now to A, because the first answer was passed on from question team B to A for answering.
Sir, time is over, sir. We can ask one question to team A and we can close, sir.
Close.
Right. Team A, last question. What is the role of allografting in this patient?
So because the burns are huge and we'll go for excision so early, just to check that our excision is complete, and take of graft will be there. We'll go for
and also the donor area supply is less because it is involving the thigh. So in view of that, we would go for a allograft cover.
We can
part I wouldn't
do a
agree.
sandwich
This is a third-degree burn. You will eventually have to go for autografting. Okay.
Yes, only interim procedure.
Yeah, correct.
Okay, sir. Thank you, sir. Now I would like to request Surajit, sir, to ask questions to Team A and Team B. Moderator.
So I've got one question for Team A. What are the 4 types of electrical burns?
Sir, it can be a arc burn, it can be a contact burn, a flash burn, a lightning injury, or a associated any other injury because of fall, any other injury.
Flash burn, flame burn, lightning, and true electric burn.
Contact. Yes.
Team B. So
Sir, are you satisfied with that answer, sir? Are you?
Yes,
can I go full marks? Okay.
Yes, we can.
Okay.
Team B. Do all electrical injuries have a wound of entry and a wound of exit?
Sir, not all will have a wound of entry or wound of exit. For example, if you have a child and is biting a live wire, that would be electric contact in series, and there's only be wound of entry and there will be no exit.
Also in flash burns.
Okay, let me give you a hint. It is in view of the first question that I had asked.
No, so electric flash burns would not have an entry and an exit wound. Also, if you're electric
A
flash
flame burn.
flame burn will also not have an entry and an exit wound.
So until and unless the patient is a part of the electrical circuit, there will not be a wound of entry and a wound of exit.
Yes.
Good.
Sir, can I give the marks to them?
Yes,
Okay, sir.
I think they have done well.
Okay, sir.
5 minutes over.
No, ma'am. We can ask Vijay Joseph, sir.
You can ask one more question, sir.
Oh, can I?
Yes,
Yes,
sir.
Okay, Team A. Team A, in a flash burn, what is actually happening?
Sir, in case of a high voltage current, there would be sparking. So the light will travel to the
one potential to other potential, sir, through a medium
From one conductor to other conductor
conductor
and in
through
between.
air.
through
Yes,
air. Yes,
through
air is the
air.
medium.
So arcing is a luminous electrical discharge. I have understood this. What is happening to the patient?
So the current is traveling from like if the patient has injury over the wrist, like it has flashed over the wrist. So the current will travel from one joint to another, like
With
to the
having a skip area in between, sir.
No.
Sir, if they
Team
can't
B.
answer.
Sir, it would be the heating up of air up to 5,000 degrees centigrade that would cause the burns.
Cause clothes.
35,000 Fahrenheit is the temperature that the air entails. That is only one part of it. What else is happening? There is something which
The
is
cloth
called
catches
pressure
fire.
wave.
The cloth catches
That-
fire, and then it leads to the flame.
Why does the cloth catch fire?
Heating up?
So because of the sparking, sir, there is a change in the electron activity, sir. So
Is
So
there
because our
any
body
other
is
reason?
grounded, our body is grounded with the earth. So from a high voltage to low voltage, when there is a sudden change.
In arc burn, the body is not a part of the circuit. The body is nowhere there.
it is only
What is
traveling to the
what is pressure wave blast?
Sir, Team B, sir. Question to Team B.
Team B, what is pressure wave blast?
Sir, in case of blast injuries, when there is a sudden increase in pressure of the air, that will cause damage to the eardrums and to the
No.
closed membranes.
No.
Yes.
A high voltage which produces a
Sir,
big
sir,
Pass
you
it
need
on to team A.
team one, team A.
Pass it on to team A.
Team A. What is a pressure wave blast?
Sir, in case of an explosion, there will be generation of a
High
large
energy shock waves.
high energy shock wave, and negative pressure will be created, which will
Negative pressure will suck the patient towards the arc.
yes, sir.
Is that what happens? It is just the opposite.
It will throw away the patient, sir.
A person standing 2 feet away will be thrown away 10 feet away. That is what is called pressure wave blast. The patient feels a pressure of almost 480 pounds, as if 480 pounds is hitting him because of that arc. And the third reason, why do the patient sustain deep burns even when he is far away? Not flame burns, not the flame of the arc, deep burn. Why does he sustain deep burn? These are usually industrial accidents. These arc burns are usually industrial accidents.
The pressure is high with which the shock wave hits the victims.
No.
So
Next steam.
when if the heated metals or some debris are thrown towards the patient at a high speed, that will
Right. So at high voltage, copper and aluminium and metal like that, they melt. And these molten metals are then thrown all around. And these go and get stuck to the patient or to the victims, and they get what is as if they have, it's a contact metal burn. Thank you.
Thank you, sir.
Now I'd like to request Vijay Joseph sir to ask questions to teams A and B. Vijay Joseph sir.
Yeah. So the question is to team A.
Yes, sir.
Yes.
What is differential pressure or delta pressure when you're looking at a compartment syndrome? Can I pass that on? Yeah, sorry.
It is the normal pressure which will be there in the intercompartmental region.
Can I pass that on to team B?
Yes, sir, you can.
The diastolic BP minus the compartment pressure.
Okay. Okay, fine. We give that to you. So the question goes to now to team B.
Yes, sir.
What is the significance of delta pressure?
So it will help us assess the further plan for the patient, whether to do a fasciotomy.
You have to give us something a little more specific than that. So for instance, what should the pressure be and what does it mean? So they said that the delta pressure is the difference between the diastolic and the compartmental pressure. So what does that mean and how much should it be for it to be significant?
Sir, it would tell us whether our adequacy of fasciotomy, the adequacy of release, whether we released all the compartments adequately or not.
Okay, can we pass that to team A?
Yes, sir. It tells about the diagnostic threshold at point which we consider to give a fasciotomy, sir.
Okay,
and it will tell us
what should the
tissue perfusion status also?
So what should it be?
So
30, more than 30.
More than 30 or less than 30?
Less than 30, sir.
Okay, fine. We give you that this thing. Do I ask another question?
Sir, you give the gist of the spotter, what to do, what not to do. A little summary like this.
So if you look at the right side, we'll start with that. You have the entire circumferential burn, although we can't see what is there on the posterior aspect. You have the leg, which is also involved. The leg appears to be slightly deeper than slightly less deep than the thigh. If you look at the coloration on the thigh, you've again got patches where there are deep blackish areas. You still don't have areas of parchment paper looking like Eshka, which is definitely third degree. So these would be very close to third degree burns. So the question is, which was asked was between tangential excision and what we call burn wound excision. What you were calling a facial excision is also referred to as a burn wound excision. So wherever you have deep burns, you will do a burn wound excision. Again, what we have found is that when you hit subcutaneous tissue, it is not the best tissue to take grafts on. So which is why even if you find that the subcutaneous tissue is viable, if you're dealing with a life-threatening injury, you would prefer to go down onto the fascia and then do an excision over there. And because you're you want all your graft to take and to lay your graft onto a completely viable bed, which you're very sure once you go onto the muscle fascia that it will be viable. The other thing is that in the leg, you have areas where you might be able to do a tangential excision. So here you do excision layer by layer. Now, there are two ways of doing this. Either you're looking at bleeding at the end point, which is what most of us do, in which case there's a large percentage of blood loss that you will have. Or you will apply, for the leg, for instance, you'll apply a tourniquet and do the excision, in which case you're looking at the appearance of the wound. So the appearance of the wound becomes a critical, and it's like the appearance of any other viable tissue that you would look at. Over there, the chances of you, so your blood loss is much less, but the chances that you might miss dead tissue in your excision. So that's about the tangential excision. Then the other thing is about the fasciotomies. In the thigh, there are three compartments. There is the anterior compartment, the posterior compartment, and there is the medial compartment. Usually, if you do a lateral incision, you can go just anterior to the lateral intermuscular septum and go down into the anterior compartment. And then you can go through the intermuscular septum. So thereby, you release the intermuscular septum also through that. Most often, that's all that you need for the release. The medial compartment, fortunately, does not, and that's the adductor compartment, does not usually need to have a release over there. In the leg, your fasciotomy, there are two ways of doing it. Either you have a double release or you can have a single release. So when you're doing a double, or maybe very rarely someone would do a triple release. So when you're doing a double release, you will go into the lateral compartment and then a short distance subcutaneous tunneling, and you reach the anterior compartment and lay that open. You can also go into the posterior compartment to the intermuscular septum. And you also have to remember that the posterior compartment can be two. There's a superficial and a deep component to it. So once you go through the intermuscular septum, you go down into the deep part of the posterior compartment. Through the lateral incision, you can also then go through the lateral intermuscular septum into the posterior compartment. So that's your one release there. And some would give an incision in the posterior compartment separately to release that posterior compartment. Allograft, if you have sufficient autograft, you're very sure of your excision, you do an early excision. In a case like this, an autograft could be done. The glycerol preserved allograft that we have remains viable only for 10 days. So when you put it onto a deep wound like this, which you don't, so except for the leg, where you can sometimes get reepithelialization under the allograft, you may not need anything. Everything else is going to need an autograft in this patient. So if you use allograft glycerol preserved, you should replace that within 10 days, ideally, if you can, with autograft. If you have enough, that can be either thin autograft or it can be stamp grafts. So I think that's my plan for this patient.
Thank you, sir.
Thank you, sir. Now we will move to the next session, like questions from other PG teams. First questions.
Rohit, you divide the teams.
I have divided,
PG
ma'am.
teams to second and third,
Yes,
because time is less now. One pattern question one. Bhattacharya sir, would you like to ask any one question?
Yeah, I'd like to ask only that if you see the picture, it is a non-symmetrical burn. That means the right side is more involved than the left. And therefore, how do you assess this prognosis of this burn when you treat, and what precaution will you take?
Team one, team A.
Sir, I would think about the etiology of the burn, sir. Usually unilateral asymmetrical, more on the one side, usually
No, this
affecting
is an electrical burn, so
Yes, sir.
etiology is known. If
Yes.
you see the wound, how does it differ? I mean, where will be your more emphatic treatment, and what will be the future? What precaution will you take so that he becomes violent?
The early decompression we'll take so that right limb is saved, sir, because that is fully involved. And
Both the limbs can be saved, as I see. Okay.
yes, sir. Yes, sir.
So that question doesn't arise which limb is going to save. Which limb, you have to see the function of the limb. Think of that. Right and left. See the area of involvement.
Sir, early tangential excision and facial excision and early skin cover, followed by proper post-operative rehabilitation protocol.
So
With
the
splintage will
Yeah.
So the knee joint is involved in
knee
the
joint
right.
physiotherapy
Knee joint.
only.
Exactly. Knee joint. A deep wound over the knee, exposing the joint maybe, or the ligaments. So what precaution will you take?
So early splintage and early physiotherapy.
See, the debridement might lead to ultimately exposure of the joint. Whereas on the left side, it may not be. It is falling short of joint or just proximal to. That's the difference on either side. Therefore, rest of the area you can graft, allograft, homograft, autograft, whatever you want. But knee area, you have to be very careful on the right side as far as functional recovery is concerned. And the other thing is that effect of burn, the intensity of effect of burn on the thigh, will it differ than on the penoscrotal area?
Sir, can we pass that question to team B because this was
Yeah.
to team A. So do you want to give the marks to team A, sir?
Yes. Yes.
Okay, I can give to team A.
Half marks. They
Half
have
mark.
not answered
Okay.
fully.
Okay, half mark. So now the question goes to team B, sir.
So you see the penoscrotal area is also involved. And how do you foresee the effect of burn on the penoscrotal area vis-a-vis thigh area?
Superficial. So the wound seen over the perineal region is of a partial is of partial thickness, is a partial thickness burn, whereas the thigh wounds are third degree burns. We can go for the exposure dressing for the perineal wound for the management, whereas for the thigh wound, we are obviously opting for the excision and grafting later on.
Suppose it is of same intensity, then what would be the difference in the wound behavior, the penoscrotal area and thigh area?
Sir, near the thigh areas, we have to splint the patient in abduction in order
No,
to.
I'm talking of the intensity of the burn on thigh vis-a-vis on penoscrotal area.
Since the penoscrotal skin is very thin, so the degree of wound would be a bit more as compared to what we are seeing in the thigh region.
What else? It will be going to be more deeper.
More
and
deeper.
easily it will be deeper.
Yes.
So where will you end up in?
We might it might lead to the involvement of urethra, and so we might be needing like suprapubic catheterization of the patient. We might face difficulty in catheterizing these patients if
No,
the
suppose you can catheterize. After that, what will happen in future?
urethral stricture will be formed.
Any other?
Team 1. Team A.
So we'll have to take care of the testes, that the cover over the testes is there, and testes preservation has to be done, sir.
And
See the vital structures like urethra, testicles, all are under, and therefore it may lead to more problematic situation for the patient. So catheterization may be possible, but you have to use undersized catheter so that you don't give a compression from inside also. But you have to be very, very careful because there's not much of tissue to resist. Straightway becomes deep. So therefore, you have to be very careful. There's a difference between thigh and pinoscrotal area. Okay. So we'll
Sir.
give half marks to it.
So each team will get a one mark, sir.
Each will get
Okay.
half.
One mark. Rohit will go to the
PG session.
one question from team or second spotter.
Yes, sir. Team 2, ma'am. Gangaram
Okay.
Hospital to team A.
Can you tell me Joule theory of electric burn along with the formula?
Voltage equals to
Power is equal to voltage into resistance is the
current into resistance.
current into resistance, sorry, amperes into.
Can you describe the theory and then the formula? The theory that is given, Joule theory.
It depends, like if there is a high voltage current, high voltage electricity is passing, the more the current, less resistance there will be, and it will generate more heat. Like more the more the voltage, more will be the resistance. So more heat will be generated.
And the equivalent
More-
tissue damage around.
If the answer is not clear, we'll pass it to team B.
And the amount of heat generated would depend upon the resistance. If the resistance is more, the heat generated would be more and the current passing would be less. If the resistance is less, the amount of heat generated would be less and the amount of current passing through the would be more.
Are you satisfied with the answer?
Yeah, the team B and the formula also.
So half
Okay,
of marks.
team B, yeah.
The
Yes.
formula that the first team provided was incorrect. They said energy is equal to current into resistance. Actually, current square into resistance.
Okay.
You want team B to pass to answer?
It's done, ma'am. Now next is team 3.
So do we give the marks or not?
Ma'am,
Ma'am,
Team B, team B gets
marks.
half for providing the correct theory and none for the formula.
It's okay, fine. Leave it.
one mark.
Team B gets, each team gets one mark.
Yeah,
it?
yeah.
No, ma'am.
Yes,
Okay.
sir.
We won't get any
Okay.
marks. We will be getting one mark. That's all.
No, A also will get 1 mark because they explained, but the formula not given properly.
Okay.
So now the question to go team B.
Team 3, BMC Bangalore to team B.
What is
To
the
team B.
most? Yes, my question is, what is the most common dysarrhythmia in electrical burns?
Team B.
It would be hyperkalemia.
No, dysarrhythmia.
Arrhythmia, so I'm sorry, my bad. It would be atrial and ventricular fibrillations.
Satisfied with the answer or not?
Yes, the answer is atrial fibrillation.
Can we give the marks to them?
Yes, yes.
Yeah.
Okay.
So both the
We'll
teams
go
have
to
got
the-
1-1.
1-1.
Both the teams have got 1-1 questions, madam.
Okay, we'll go to the second spotter.
Yes,
ma'am.
yes.
Yes, ma'am.
Dr. Sanjay Kumar Giri.
Yeah.
We invite Sanjay Kumar Giri.
Yes, madam. We'll start, madam.
Yeah, yeah.
It's the first question to team A. You have seen this case. Can you tell me what are the clinical examination you are going to do in this case, if you get it?
Yes, sir.
Yeah.
Check. Clinical examination would start with the attitude of the limb and joints and the extent of the scarring, whether it is a linear or broad band, the size and shape of the scarring and the areas involved. and each of the scarring, whether they are immature or mature, and whether hyperpigmented or hypopigmented, and then it proceed with movements in the joint, both
What are
active
the
and passive.
what are the movements you are going to see?
Sir, in shoulder, I would check for abduction, adduction, flexion, extension, and internal rotation, external rotation, sir.
Yeah. Any other thing you want to see in examination?
And
So the angles we'll see of the range of the movement, how much he is able to do. The patient is able to do.
But still then, the major thing which is required for any treatment management.
No, if you are not
Sir,
satisfied, pass on to the team 2.
Sir, what part of the axilla is involved?
axilla is
like
involved,
the axillary fold or the dome or the posterior
or the
triangle?
entire axilla.
Yeah. All right. Any other thing regarding the management?
I would
Sir,
check for the donor sites also, the adequacy of donor sites.
That is all right. But before donor side, any other thing you must see?
So can we answer?
X-ray I would check, sir. The joint status.
Okay, it is madam. Okay, but any other thing, team B, you can tell?
Sir, I would like to measure the apparent and the true defect.
Yes,
by marking the common landmarks.
Apparent and true defect, that has to be also seen. Yeah. So madam, we'll go to the next question to the team B, na?
Team A will get the full marks.
Yeah.
Yeah.
Okay.
They have almost seen. And team B, next question is, why is axilla particularly prone to this post-burn contractures? You got it, my question? Why axilla is most prone to this post-burn contracture?
So because of the normal attitude of the child or any person to keep it in a position of adduction and flexion of the elbow, and
Yes,
so the result of which the raw areas fused together, that results in formation of post-burn axillary contractures.
Yeah, because of this position, yeah. This is why. This is all right. Then question to team A. Can you classify the post-burn axillary contracture?
Sir, it goes by Kurtzman and Stern's classification, which is classified it into 4. Type 1. Type 1 is type 1A is which involves the anterior fold. Type 1B is posterior fold. Type 2 is which involves both the anterior and posterior folds. Type 3 is which involves along with the folds the dome of the axilla. And type 4 is which involves the periaxillary regions.
Yes, all right. Any other classification you know?
Sir, Hudson's class.
Hallock, yeah. You can tell. Do you know that one? Hallock classification?
No, didn't remember.
Team B? Team B, can you tell Hallock classification?
So we have an Ogawa classification for this.
No, what Hallock classification, that is like isolated anterior wave and all those things. Do you know that one? Isolated anterior wave, isolated posterior wave. Anyway, so madam, we can give the marks to team A. The
Yeah,
next
team
question.
A will get the full mark.
Yeah. Next question.
Okay, sir. Question to team B.
Yeah, team B. So what is the optimal time for surgical release of the axillary contracture, bone contracture, and why? Team B.
Sir, optimal time would be once the
functional disease.
If there is no limitation of function, if it is only involving the axilla, it would be to wait till the scar gets mature and then plan for an incision release.
The scar mature at what time usually?
3 months.
How long you will wait?
3 to 6 months.
3 to 6 months.
6 months, yeah.
6
And the other thing, whatever you have told, that functional disability, if it is
Functional
not there, it
disability.
can be done. Yes, madam, we can give marks to the team B.
Team B. Okay. Question to team A now.
Yeah, that is 6 months, yeah. And then next is the question for the how are mild axillary contractures managed surgically, as you have seen in this case?
Sir, we'll go for local tissue capsule like Z-plasty, or we can go for a 5 flap or jumping flap plasty, or we can go for a square flap.
Local tissue rearrangement.
Z-plasty and local flaps. Z-plasty you have told. Any other things?
Square flap and 5 flap Z-plasty or multiple Z-plasties we can do, sir.
In this case, what you will do?
So this is involving both the anterior and posterior folds, sir.
So we'll go for release, incisional release with fish tailing, sir.
Okay, madam, it is all right. We can go to the second question to team B. Team A is all right, madam. The answer they have given.
Yeah.
Team B, what is the role of skin grafting in axillary contracture?
If the axillary contracture, if we are doing the incisional release and the area is large and we cannot do any flap coverage for the patient, for that patient, we can opt for STSG or intermediate thickness grafting for the patient.
So what is the
no vital areas?
Provided that no vital areas are exposed, we can go for split thickness.
What is the intermediate thickness? Can you tell?
So intermediate thickness would be the thickness between 0.30 to 0.45 mm.
0.0
0.030 to 0.045 mm.
Sure. Okay, all right. Then, madam, you can give the mark to team B.
Okay, sir.
So, team A, can you tell me what are the principles of release of this management of axillary burn contracture? There are certain principles while releasing. Can you tell?
First thing, we should try for a complete release, sir, and it should have a fish tailing at the ends, and we should try to give a abduction of around 90 to 110 degrees. And we should give a stable cover. In case vital structures are exposed, then we'll have to go for a flap cover, sir. If not, we can go for a skin.
Any other thing? Any other principle? Team B, can you tell?
So we have to give the incision across the maximum tension line.
Yes, across maximum tension. Yeah. Any other thing?
We should try and avoid exposure of any vital structures. And there should be complete release of the
Complete
contraction.
release, they have told. That one thing you have told.
Unstable scar or hypopigmented patches or ulcerated.
You have told maximum tension, and the other thing is that the underlying
Preservation
structures.
of the axillary hair, sir.
And neurovascular.
Neurovascular.
So, madam, partial you can give because two things they have.
One. Okay,
Madam, they
sir.
have told about the maximum tension they have released, and the other thing is that underlying structures that should not be exposed.
So one each to each thing.
Yeah.
Okay, sir. Now the question goes to team B.
Yeah. So what is a propeller or central axis flap? Do you know that which is used for the axillary contractures?
Yes, so it is basically done when the cupola is not involved. Basically, it is a subcutaneous flap. We propel the flap 90 degree, the cupola, the remaining cupola, which is spared, we just propel it 90 degree to cover the vital structures if exposed after the incisional release of the contracture band.
It is a what type of flap? Fasciocutaneous.
Fasciocutaneous flap.
Yeah. It is mostly used for the which type of contracture? That classification, if you think, mostly it used
it's a
for
type 2 sparing the cupola.
the type 2, yeah. It's okay, madam. You can give the marks to.
Okay.
Sorry
Team B.
to interrupt, sir. I think.
Question to team A. Team A. It's team A, na? Yeah.
Yes, sir. Yes, sir.
What are the regional flaps which you can use for the axillary contractures? Got it?
We can go for a pedicle parascapular flap, pedicle LD flap, and DP flap.
Serratus anterior, sir, we can use, or internal costal artery.
Intercostal artery ICAP flap, or a posterior arm flaps.
No, you have told parascapular, scapular, any other?
LD, sir, latissimus dorsi.
Latissimus dorsi. Any other than that?
ICAP flap, sir, intercostal artery perforator flap, or a posterior arm flap.
From the arm.
Any one thing you are missing? One important flap which I usually give.
Team B.
So we can
thoracodorsal artery perforator flap.
TDAP flap.
Thoracodorsal artery perforator.
These flaps are mostly used for the type 3, yeah?
Yes.
So, madam, you can give mark to team A because they have told almost all the flaps.
Okay.
Next
Okay.
question to team B.
B.
Yeah. What is the role of, can you tell in management, is there any role of dermal substitute? Now they are used a lot of dermal substitute. Can you tell the role of dermal substitute in management of the axillary contractures?
Yes, sir. After releasing, after doing the incisional release, instead of covering it with the skin graft, we can opt for the dermal substitutes. The reason being, it is more it gives more pliability, and the pigmentation would be good after putting dermal substitutes. And
What is the advantage of using dermal substitute, which is now
it
used?
provides a good dermal layer for the skin, not just the skin skin glands. It provides a good dermal layer.
Thicker dermis, yeah.
thicker dermis.
Any other thing? Thicker dermis, any other thing?
It will provide skin pinchability, viability, and
pinchability, pliability.
the amount of contraction that
Recontracture, chances of recontracture is this.
Madam, it is okay. You can give marks to them.
Sorry to interrupt.
Yeah.
I think we are 10 minutes is over, sir.
10 minutes over, yes.
If you, Lakshmi ma'am, I think.
Yeah. Dr. Giri has covered very nicely all aspects of the PBC axilla. Team 1A, what is the commonest type of PBC axilla you come across? What type? You described so many classification.
Yes.
Usually, what type of axilla contracture you will come across?
1A, sir.
1A, type 1.
And you told, okay, team B?
Sir, ma'am, it would be involving.
If it is, that is correct only. So either one-fold or two-fold involvement. So they get the mark. And if you told the true defect has to be measured, how will you measure?
Ma'am, we choose particular landmarks against which we first measure.
What landmark?
The landmarks would be the acromion process, the midpoint of the humerus in the supero-inferior direction, and in the antero-posterior direction we can have the mid-axillary line, and on inferior aspect, superiorly we have acromion process, inferiorly we have ASIS, laterally we have mid-humeral point, and medially we have mid-axillary line as the...
Always you should take the bony points. So you
prominence.
told anterior superior iliac spine and the mid-humeral line and anteriorly posterior. The mark is given and you either normal axilla opposite side or the same
or the
straight
similar build
same
person.
age. Okay, marks given to you. Team A, if you plan any local flaps, jetplasty or 4 flap, 5 flap or 7 flap, what will you check for?
I'll check for transverse availability of skin perpendicular to the axis of the release one.
And also that the axillary dome skin is not coming to the, it is not getting,
it should not be displaced. The dome skin should be not displaced, and also the there should be availability of flap, because skin around the Z-plasty, laxity of the skin around for the flaps to move, the Z-plasties. And also maintain the vascularity of each of the flap is also essential.
Are you there, madam?
Hello.
Hello. I think
Madam
we
is
lost-
not.
I think we lost her.
Madam is not heard.
Lakshmi madam.
Okay, can I have a rectification answer? If I am allowed?
Yes, sir.
Rohit?
Yes, sir. Yes, sir.
I asked to the team A, they have asked about the movement of the shoulder joint and especially on the abduction, how much is the maximum abduction you have to achieve on table?
135
They told the
degrees.
answer was 90 degrees.
135 degrees, sir.
135, no.
110 degrees. Sir.
110.
110.
120.
Team B.
So 110 degrees.
90 to
No.
120, sir.
No. On table, you have to get about 180 degrees. If you want to get a complete correction of the abduction deformity that has aroused from the postbone contraction. And second is, while presenting, you have never mentioned about the extrinsic contracture of the abdomen and which structure has been distorted in this case.
Umbilicus.
Yes.
Umbilicus.
So when you give a presentation, you have to complete all
Okay.
this.
Yes.
So I do not tell about the minus marking, but positive will depend on your judge what the C thinks about it.
That's
Thank you very much.
I think,
Rohit,
ma'am,
my time is over, or any one more question can I ask?
you have to ask
Madam,
one question to team B, ma'am.
question, for the team A, do we give marks, madam?
Which one?
For the
The previous
question,
question, ma'am.
What they answered, because my net was problem. So I asked if you local flap plan, so what will you look for and what precautions you will take?
Yes. Local flap, I'll check for laxity of skin in the release site and also not to displace the dome of axilla and other landmarks. And to give proper vascular flaps, the vascularity of the flaps also should be checked up.
What precautions
And,
you will take when you plan jetplasty in a scar area?
Yes, ma'am. We should not give acute angles to the Z-plasty.
Yes.
And
What are
the
the
flap also should be
complications?
having subcutaneous tissue, sufficient
Yes.
subcutaneous tissue.
Yes, yes, correct. And team B, if you come across that you have released the skin and the scar tissue, but you could not able to abduct the axilla. It's a long-standing axilla contracture. How will you address this problem? Team B,
Ma'am, if I have not gotten an adequate complete release that I am expecting, then I would go for traction and splintage and traction, serial splintage, or applying an external fixators and traction till I get optimal release, and then I'll plan for a graft or a flap car on the second sitting.
so you stop with a partial release and will you cover that or you don't cover?
Yes, we'll cover it with a graft and we'll go for this ural splintage.
If you do a forceful abduction, what may happen?
Ma'am, the vessels nerves
Team
would
A, your answer is correct. Team A,
the vascularity, axillary artery might be injured.
injured?
The brachial plexus, there might be a traction injury to the neurovascular bundle.
May go into traction, injury. What exactly happens?
Thrombosis of the axillary artery or neuropraxia of the brachial plexus nerves coming up.
And the shoulder joint dislocation also can be there, ma'am.
How will you know that? How will you detect it?
And there will be the shoulder will come out of the glenoid fossa.
There will be malposition of the shoulder.
On table, you should check, no? On table, you have to assess. Is there any problem or not?
Will be there, ma'am, if it has come out.
Malposition of the bony contours and landmarks.
Where are you going? In team B?
Ma'am, there'll be tractional vascular spasm of the axillary artery, and there'll be tractional neuropraxia to the brachial plexus. Also, there'll be shoulder dislocation or subluxation, which we can see.
How will you detect? How will you detect? They told all these.
Ma'am, there will be a loss of the shoulder
How will you
contour
detect?
and the.
There'll be loss of the shoulder contour.
You told vascular spasm, told brachial plexus traction. So how will you detect? Isn't it that is clinical findings you should know?
Ma'am, we'll feel it free and
any crepitus or click will check. Smooth rotation of the joint action. We'll do all abduction, adduction, flexion, extension, and see. Look out for the smooth.
On table when you do the.
Ma'am, there'll be apparent lengthening of the I guess.
Shoulder ROM will be restricted, ma'am. If it has come out, then what adduction it was doing earlier on the table, it will not.
Full range of motion will not be.
Usually you don't go up to that extent, isn't it? Long standing, when you do the abduction, I cannot give the, you both will get only half marks, because when you do abduction more than what is required, there will be spasm of the vessel. So how you will detect is you have to feel the pulse, distal pulses, whether it is present or not clinically. So always when you splint, immediately you check for the radial and ulnar pulses. And the clinical sign and post-op period will be the, which if you answer, I'll give the mark. So which part of brachial plexus is stretched? And what will be the sign?
Team A or team B, ma'am, question.
Both, because it is the question
Clumpy is
asked.
paralysis.
Team A, can you
Claw
answer?
hand and is paralysis.
Median and ulnar.
Claw hand and clump case paralysis.
Okay. It's wrong.
Ma'am, which
Team
team?
Question, can you
Team
please?
B answered, but it is wrong.
Question, can you please repeat, ma'am? There was a signal.
Which part of brachial plexus will be stretched? You told brachial plexus. Brachial plexus is very like various parts are there.
Yes, ma'am. The cords at the level of shoulder, cords will be
Which one?
affected.
Which one? Specific.
The posterior cord.
Medial, lateral, posterior.
Posterior cord, ma'am.
Yes, I give mark for you. What is the clinical finding?
There will be drop.
Pardon?
Wrist drop and finger.
Yes. So
finger
that is
drop.
the clinical sign you will check in post-op period. You will ask to extend the wrist. Okay?
So team A gets the mark, madam.
Yes, ma'am. Time is over, I think. Otherwise, if multiple joints are involved in the upper limb along with the axilla, elbow, and wrist, what is the order of you are addressing? How many stages are required? Team B?
Team B.
First,
We usually go from proximal to distal joints. So we'll start from releasing axillary contracture to elbow and then to the wrist contractures.
how many stages? Only upper limb involved, nothing else.
3 stages.
Team A?
It can be done in 2 stages, ma'am. We can correct the alternate joints in one stage and do the remaining joint.
The axilla and
Both the
elbow.
teams will not get a full marks. Yes, proximal joint has to be released first, but depending upon the deformity and the
Function
type
requirement.
of contracture also. So elbow inflection position, there is no need to address initially. The proximal, the shoulder and the hand also can be released. Okay. So if sufficient donor site is there, you can address all the joints also. So depending upon the severity and the requirement. So at the earliest, if you release everything, the splinting also, there will not be any problem. Okay. If it is only the upper limb with the all joints. Okay. The neck is there, that is different. I think I have done, and my time is
what
also
is the
over.
marking? What is the mark that I have to give for the team B, madam?
Equally
Team
distributed
B,
marks.
half marks they will get. Stages, it can't be 3 stages. They can be done in 2 or single also.
So only team B gets 1 mark.
Yes, sir. Yes, madam.
Okay.
Uh, From judges side, ma'am, you have any questions to ask for the PGs?
You show the second photo also, Rohit.
Yes, ma'am.
Team A, what is the procedure you will select for this case?
This is mostly a type 1B involving the posterior axilla extending onto the chest, the contracture band. It has got a linear band of contracture extending from mid-arm to at the level of nipple on the chest.
Procedure, no need for description. What
It
you
has
will
got
do?
skin webbing, so I'll go for again local flaps.
Any name first?
Square flap.
We can go for a 5 flap Z plus T or a square flap.
Safe, marks given, marks given. Okay.
Team B, ma'am, question.
One
Team
more
B?
question to team B.
Team B, which procedure is best for axilla to avoid splinting?
Flap coverage to be done in spite of covering it with split thickness skin graft.
So what are the problems with the flap cover also?
Ma'am, the area after releasing of the contracture band, it should be less for it to be covered with a flap. And
also when we use the local flaps, there would be the donor side morbidity that would need a graft cover. And this donor side
You
should be
told the
uninvolved.
flap, I accept that. Okay. Flap is one. And if you if the defect is very large, okay, so how will you tackle that situation?
Then we would either go for dermal substitutes or free flap coverage if dermal substitutes are not available.
if dermal substitutes are not available, we can go for free flap coverage.
A little more point I'll give you. The area is the defect is arm, axilla, and chest wall, isn't it? Once you recreate.
Ma'am, we can also go for multiple flaps from two sides. We can do a scapular flap along with the lateral arm flap if it requires that kind of a coverage.
Any alternative, team A?
Ma'am, we have to look into that the dome of the axilla and across the joint there are flaps, and rest of the areas of scars, which is the chest and the arm, can be covered with SSG itself.
Wonderful, correct. So you will get one mark and they will get 1 mark. Okay. They told the flap and you told what is required for the large area, right? Okay, I'm
Questions from
done.
Angelina, ma'am. Any question?
In the acute burn stage, what is the position that is to be maintained?
For team A.
A. Team A. In the acute
90
burn.
to 120 degrees splintage, ma'am, with an aeroplane splint.
That is not only I want two positions. That is, one is you are telling about the shoulder.
Yes, sir.
Then other shoulder has, what are the movements in shoulder?
Ma'am, adduction, abduction, flexion.
So I want one more position. One more position. You told 80 to
Yes,
120 degrees of
and
this thing.
external rotation, ma'am.
You want it in external rotation or something else? Goes to team B.
Extension.
Internal
Extension,
rotation
ma'am.
to
Extension,
hand to mouth
extension.
position is preferable to internal rotation.
No. How much of flexion do you give to that? Abduction is 80 to 120. Flexion is?
Is not there. Flexion is not.
It goes by a specific name. I'll give the answer. It is 15 to 20 degrees of flexion, and the position is mentioned as scaption, so that the shoulder doesn't go to complete the adducted position. So it is 80 to.
Hello, ma'am.
120 degrees of abduction with 50, and that position that is in the horizontal flexion position, and that position is called as scaption position. So that has to be maintained in acute. So I give 1 mark to team A and none to team B. And coming to the principles, can you, there were few principles that were mentioned. So I just want, that is the, I just want, what are the priorities or the sequence in which you arrange the principles? That goes to team B. Reconstruction proposal principle, and that is actually mentioned by Fieldman. And what are the sequences? There are actually nine given, and I will at least want 5 from you.
Ma'am, the contracture release should be across the maximum tension.
No, first is what the assessment should be.
So assessment of the deformity, how much contraction.
Yes, good one.
Involvement. The donor side, the surrounding structure assessment, and the donor side assessment. Then assessment of the range of motion, checking the joint.
Good. Two. Yes.
And then we measure our defects apparent in the 2 defects that the actual dysfunction the child has.
That doesn't
then we
come
plan
into
for
that.
a release if the scar is mature or not, whether we will just go for
yes, good. Third is scar maturation.
No exposure of any vital structures should be there.
That is in the release.
At the line of maximum
Fourth
tension.
is regarding the release. What will be the principle of release in that?
We start with an incision at the line of maximum tension with fishtailing
That
at
is
the ends.
what release precedes? Extrinsic release or intrinsic release? Which should be done first?
Intrinsic release, ma'am.
Extrinsic release should be done first, ma'am.
Okay. And how do you orient the scars?
Yes. Relax. The incision should be planned according to the relaxed skin tension lines.
Yeah, parallel to the RSTL. So these are the first 5 principles proposed by Feldman. And the others are, of course, 6th will be to identify donor site. 7th will be to resurface according to the aesthetics. And 8th will be to match the donor thickness. And 9th, last, will be to protect the new scars from hyperpigmentation and ultraviolet exposure. So good, I'll give the marks to team B because you have almost given the, I think I'll stop with that.
Thank you, ma'am. Now, any questions from Bhattacharya, sir?
Yeah. I was observing first a comment that both the teams use Z-plasty very casually. I would like to know that in both the cases, is Z-plasty is possible? Because 2 things happen. One is the vascularity of the flap. Other is the mobility of the flap. You're trying to place the incision straight to the scar, therefore the mobility is less, obviously. And the vascularity is also to a great extent compromised area, deep scar. So my suggestion is that do not use the term Z-plasty very easily because there are certain prerequisites for Z-plasty. And you must read that and understand that. Now coming to my question is that you have mentioned beautifully so many flaps to Dr. Giri. Are these flaps you are planning to cover the whole raw area following release of the contracture?
No, sir.
What is your plan? Why? What type of flap you are planning for which area mainly? For whole of the post-release raw area?
No, sir. The axillary dome primarily, and if any vital structures are exposed.
Where you want to place the flap?
So at the
What is
maximum
the
tension when we release, there will be raw area such that near the dome.
in axilla, this
In
contracture previous picture you can give. In axilla, where would you like to place the flap and for what?
Sir, it should be across
Where
the
will
dome
you
and
insert?
across the dome involving both the folds also, sir, so that recontracture doesn't occur.
Okay, so across the dome, why? Why across the dome you want to put a flap? Why not a graft?
Chances of recontracture are highest at that.
Chance
And
of
that recontracture and exposure of
recurrence.
endovascular.
So to prevent recurrence, you want to put the flap at the dome and not for the whole raw area which you are creating following
Yes.
release. Okay.
Yes, sir.
Now, you have not mentioned one important and simple flap. Can anyone team mention? Local flap, of course. You can I see the earlier picture?
Yes,
First
sir.
picture? Yeah, now you see it. See the right side. Any other technique? Simpler? Which will bring the flap to the peak, to the dome?
Bipedical.
Bipedical.
Bipedical
Absolutely.
Yes.
Absolutely. So why you did not mention that? It's a much simpler technique. Now tell me the principle of bipedical flap.
Sir, in a bipedical flap, we give 2 incisions which are long.
Wait. When you are planning, how do you plan?
Sir,
You cannot put 2 parallel incision anywhere.
No,
You
it
have
is
to plan.
along, sir, it
Can
is
I
along the
answer?
2 folds, like 2 contracture bands. We are giving the incisions.
Can the team A? Yeah.
Sir, first we have to mark the proximal and distal points of the contracture band, sir. And little distal to the distal point and little proximal to the proximal point, we'll have to mark the lines. And we have to release the distal one first and see how the flap is moving and then commit to the proximal incisions.
I am asking pre-operative planning. First line you will draw with your pen where it is.
Across the contracture bands.
No.
The band will mark.
Okay, the answer is joint line. You will draw the joint line. And now, how will you place the 2 parallel incision? Tell me.
So it will
After
be along
joint line,
the.
then we mark the contracture bands.
See, 2 parallel, one line in the center you have drawn
Yes,
arbitrarily. Joint line. Now you have to make 2 parallel incision. So what is the principle of these 2 parallel incision?
In such a way, the
Neurovascular
island of flap comes to the dome.
Principle, flap principle. Team B?
So it shouldn't expose any neurovascular.
No, flap principle. That means when you're making 2 parallel incision, it is a bipedical flap.
Yes.
It's getting supply from both the sides.
Supplied from two sides.
So it is very safe.
We should not give a circumferential.
No, question doesn't arise. Okay.
What is
So
the
it's a
geometry?
bipedical flap. So the
Dimension.
bipedical flap goes into the dome.
Dome, cupola.
And on either side you have raw areas.
Yes.
Okay.
Should be grafted.
Now what do you do to the raw area?
We should be grafted, sir.
Should be grafted.
You should be grafting.
Yes, sir.
So even the chance of recurrence is less because of the flap in the dome, as well as because of something else. What is that?
Both the contracture of the grafts will not let that.
So both the grafts will contract and will neutralize each other.
Neutralize it.
So what is the advantage of this bipedical flap there?
It avoids
Avoids
recurrence.
Exactly. It prevents recurrence. So in such area, instead of Z-plasty, because Z-plasty, too many flaps, scarred area, compromised vascularity, less mobility. Bipedical flap, safer flap, both sides vascularity. And graft or contracture is neutralizing each other. So which one is better?
Bipedical release.
Thank you.
Thank you,
So
sir.
what is the mark that I have to give, sir?
1-1.
1-1. Okay.
Now go to the PZ question session. Next, team 4, Sage GS Medical College to team A. You have any questions?
No questions, sir.
No questions. Okay, fine. Now, team 7, Ames Rishikesh. You have any questions to team A? Team 7.
No questions, sir.
Okay. Team 8, Ames Bhubaneswar. You have any questions?
Yes, sir. Can you please tell me, in a case when we have released the contracture and resurfaced using skin graft, what would be the splintage protocol? For how long will we give?
We'll go for an aeroplane splint. and we'll keep the splint for 6 months, and nighttime splintage will continue.
So
for the
total will be
next
for
6
1
months.
year. 1 year will give us splint.
Okay. Yes. Okay, sir.
Now, team 9, Southeastern Railway. Any questions to the teams?
Team B.
Could you
Team
please
B.
Team B.
Team B.
yeah, could you please elaborate what is a jumping man flap?
Jumping man flap, basically it is a 5 flap, it consists of 5 flaps. We have a VY advancement flap in the between, and then we have 2 Z plasties. Basically firstly the V flap advances into the defect in a VY manner, and then the 2 Z plasties transposes to give a linear scar in a zigzag fashion. So basically, it consists of it consists of 2 Z plasties and 1 VY advancement.
VY advancement. Okay, thank you.
So we give the marks. Okay.
Any questions from other panelists? Or any?
Can I ask one thing?
Yes, sir. Yes, sir.
Basically, I have to make a point that the question of Dr. Lakshmi left unanswered. That in full abduction, how will you judge that shoulder joint is not dislocated? So my point is that humeral head will bulge into the axilla. On table, you can assess that, and that will show that the shoulder has been dislocated. While you are hyperabducting it to full extent, as Dr. Arun Chaudhary said, up to almost 180 degree. It will not be 180 degree, 160, 170 degree.
Thank you, sir. Ma'am, if you permit me, then I will move to the next third spotter.
Yeah.
I would like to request Neela ma'am to start the questioning.
Yeah, thank you. Can you hear me?
Yes, ma'am.
Okay. So first of all, we'll just start with one small observation. The thickness of the skin grafts, I think both the teams should have to look up again, huh? I think team B said 0.03 to 0.45. If you take such a thick, it will be nearly a full thickness graft. So not an intermediate thickness. So please have a look at that. Okay. So now we come to this spotter. Can you hear me well?
Yes, ma'am. Yes.
Okay. So this is a patient who's a 60-year-old patient who sustained a 30% burn surface area burns, but she came to me 3 months later with a 20% post-burn raw area in the perineum, in the thighs, both buttocks, and there was infection and it was non-healing. Now, first I want to start with team A. What is the box score in this patient? Can you tell me that? And is it reliable as of now in this patient?
Box score is for acute burns survival index, ma'am.
Okay. So what is the box score anyway in this patient?
Age plus total burn surface
Surface area.
So now if you're saying that it is 20% raw area, so we'll consider 20 plus age, that is 60. So
team B, you want to try?
60 would be
team B.
80%.
Okay, so madam, marks go to nobody.
Okay.
It is 60 plus 30 was the PBSA when she started out. So the box score will be 90. Now the thing is, why I asked you whether it is valid now, you made a valid point, team A, that it is only for acute burns. So it is not valid. Even 90, you say that it is not going to die, but then a person who comes like this with a non-healing wound may die. So it is not a good indicator now. Team B, the question to you. What is the box score that is considered unsalvageable?
60%. So 60%, ma'am, 60%. More than 60%.
60% of what? Team A told you what the box score was. It is age plus percentage burn.
Percentage of burn.
So what
More
is the
than 100
percentage that is? Team A, please.
Ma'am, more than 100 is
high mortality, indicates 50% mortality.
Yeah. Anything else? You can better the answer. Okay. So 100 is serious, yes. But if a box score is more than 130 to 140, it is unsalvageable. So the marks will go to team B, madam. Sorry, team A. The mark will go to team A, half mark.
Team A, 1 mark. Yeah. Carry over. Okay.
Now, second, we'll come to this burn per se. This is a burn in the posterior thigh, in the perineum. So, and deep. So, what are the special precautions? What are the difficulties in the management in this case? The question to team A.
Ma'am, first is the
Positioning of the patient would be difficult and maintaining hygiene.
What are you going to do? How are you going to position?
Ma'am, we'll place the
Prone.
position in lateral or in prone position.
Prone better.
Yes, ma'am.
And
then
then?
we have to make sure that once she passes stools, the area has to be cleaned properly, and if any
Soiling
dressing is
should be
there,
avoided, and dressing
Yes.
should be changed frequently.
Yes. What dressing will you use? Is it open or closed?
Closed.
Okay. Closed is difficult, no, in that area?
Ma'am,
You said it's going to be changed frequently also?
near the inner clefts, we leave it open, ma'am, and the rest of the area, like on the thighs and on the lateral portions of the buttocks, we can go for closed dressing.
Okay, agreed. Anything else would you do? Any other difficulties here? Any other way you'll keep the legs?
Ma'am, we can.
It should be abducted,
Separated.
ma'am. Abducted.
Okay.
And in between, we should tell her to
We
flex
can
the-
put a spacer in between. And
Exactly. And one more difficulty is going to be when team B, you want to try the last difficulty?
Ma'am, when we would be planning for the grafting for this patient, we would face difficulty in finding the donor areas because most of the bilateral thigh is involved.
Yes. And fixing of the graft.
And also, since the granulation tissue is looking more pale, so we might need to optimize the patient first before planning for any.
So these are the difficulties. Both teams will have marks, madam.
No, the primary mark was to
Team A, yeah.
Oh, okay.
The team A.
Okay.
Team B. Now, when you see any burn wound, what are the signs that it's going to tell you that the burn wound is infected?
Ma'am, appearance of any hemorrhagic areas inside the wound. Also appearance of any satellite lesions in the periphery of the wound.
Okay.
Appearance of any necrotic patch or...
All these are the same. You're going necrotic, hemorrhagic, this one, everything is the same. What else?
The becoming of wound, the presence of slimy layer over the wound, and presence of purulent discharge underlying the eschar, and
also the clinical parameters, patient will be febrile.
No, not the, I'm only talking about the wound. Team A, one important hallmark which you should always think when you see a wound becomes infected, something will happen to the wound.
Soakage of the
Team
dressing.
A
soakage
can
of the dressing.
Yeah, that is fine. Team A,
there will be change in the thickness of the burns,
First
and the
class.
surrounding erythema can be seen in the normal skin, ma'am.
yes.
If the
So these
infection
are
is
the two
localized.
important marks. One, the superficial burn becomes deeper. It's a very hallmark, increasing eschars. So that is a hallmark of infection. And second, there will be erythema, but then that team B
normal.
is dead. So, madam, marks to team
Equally
B
distributed.
first, equally distributed to both the
Okay.
teams. Okay. Now,
Now the
so
question to team A.
the question to team A, yeah. How will you define burn wound infection and how will you confirm that? In what is the most common organism in burn wounds nowadays?
Staphylococcus.
Is it? Okay, we'll
Now
leave it
this
at that.
one-
We'll go back later. Answer the rest of the questions.
Burn wound infection can be confirmed by biopsy, which shows more than 10 per 5 microorganisms per grams, ma'am.
No microorganism.
Biopsy
You
was.
cannot do microorganism count. What is that called? 10 power 5?
Colony forming units,
Yeah.
CFUs.
Colony forming units per
gram of the tissue.
per gram of tissue. From where will you take the biopsy?
Not the dead and eschar part, ma'am. The
Team B?
one layer beneath it.
Team B, what is the most common organism?
The most common organism is Pseudomonas aeruginosa, followed
Yes.
by Staph aureus. And then I would take biopsy from the granulation tissue that is immediately adjacent to the eschar or underneath the eschar.
Okay. Only one biopsy?
Two, ma'am, two biopsies.
Not necessarily any as much
From
as
two
needed,
sides.
huh? But always at the erythematous and adjacent sites, not exactly at the eschar. You can send the eschar, you will find infection maybe, but it's not going to be valid. Okay. So, what is colonization? Suppose you see only a greenish discharge, greenish soakage of the wound. Do you say Pseudomonas infection or you say something else?
To team B, ma'am. Question.
Team B.
Ma'am, if there is only a greenish infection, that means that the infection is only up to the eschar and the subeschar level. It is not invading the live tissue.
Why the green?
Ma'am, that is because of the pigments produced by the organisms, the pyocyanin.
By Pseudomonas, especially.
Pseudomonas.
Okay. Team, the question to you only. Suppose you were saying the patient has gone in for burn wound, invasive sepsis. What are the clinical signs now that you will look for?
Ma'am, it comes under the constellation of SIRS. So there'll be the temperature would be either less than 36 degree Fahrenheit or more centigrade or more than 38 degree centigrade. TLC less than 4,000 or more than 12,000.
Again, we have not gone into florid sepsis. We are suspecting that the patient is going in for invasion and sepsis. So what are going to be the initial signs, please? By the time it becomes leukopenia, by the time you have a low fever, the patient is already far gone. First few signs: fever,
tachycardia, increased heart rate, tachypnea.
Yes. Then?
Decrease in urine output.
Very good. You go for rounds, you talk with the patient, suddenly you realize something is wrong. What are those things?
Lower lower BP, BP is in lower ranges.
Team A?
There might be altered mental status like drowsiness or anything, and worsening of the wounds and dressing.
No.
And,
clinical signs. Please don't go back to all. And then any blood parameter, which is
leukocytosis and we can check
Thrombocytopenia.
CRP and procal also.
Okay. So one important sign, fever, tachycardia, the one important sign is mental confusion I was looking for. Irrelevant talk. Suddenly the patient will say, I had altered sensorium and drowsiness is not what you have to be specific and say. Suddenly she will say that she's had rice and fish when nothing would have been given to her in the morning. So that is an irrelevant talk. It's a sign, first sign of sepsis. Okay, and decreasing platelet count. Madam, both teams will get marks. B will get the primary, and for answering at least the leukocytosis and diarrhea, paralytic ileus. So these are all the signs. Okay, the question to team A now. You know what a biofilm is?
Yes.
What is a biofilm?
Ma'am, it is a layer of
it is slimy layer formed by the organisms which produces a pseudocalyx. It's an extracellular polymeric substance of the bacterium, which forms a slimy layer over the wound.
What does this biofilm actually do? Is it useful to the bacterium? Is it useful to us?
It helps the bacteria to adhere more to the wound.
And it does not let if any local antiseptic.
Antibiotics don't penetrate it.
Yeah, so if
helps
the organisms form a biofilm, you are not going to have antibiotics and immune clearance. Both will not occur. So a biofilm is the way the wound infection occurs. Team B, can you tell me what is done to counteract biofilm?
Ma'am, we have to, when we are taking the patient into the OT for debridement, we have to make sure that we rub the biofilm using a dry gauze piece to remove it, or we can go for the debridement of the biofilm.
No. You see this patient, you have obvious areas of HR, but then the entire area would be filled with the biofilm. What can you use? Locally, can you use any specific dressings which will remove the biofilm?
Betadine.
Team B.
Yeah, ma'am, we can use a silver sulfadizine, silver nitrate.
No. Ma'am, we have to go for the betadine solution dressing or the saline, followed by saline dressing.
Betadine will not remove biofilm actually. So the answer be team A, can you try?
Silver-based nanocrystalline dressing.
Nanoparticles of crystal silver dressings we can use, or we can use chitosan or PHMB based dressings like Maxocell, or we can use cadoximar iodine, ma'am.
Exactly. Okay, at least something. So you can use either cadoximar iodine, or you have povidone iodine will not help, team B. So cadoximar iodine, yes, but then more better would be.
Ma'am, we can also go for bromelain, Nexobrid or bromelain, enzymatic, any enzymatic debridement. We can go for enzymatic.
Fair enough. Anything else? Any other special dressings?
Tapain ureas.
All those are enzymatic. Any other dressings?
Antibiotic base.
Ma'am, we can avoid the
NTWT, ma'am,
using
we
of
can use.
gelonate or the paraffin gauze. Avoid using paraffin gauze and we just use saline soak dressing so that the biofilm sticks to the dressing when we peel it off in the next change.
So, okay, but that does not really occur. So you have to either use enzymatic dressings, or you use some dressings which will continuously give the antibiotic. Like silver, just using silver sulfadizine, silver nitrate will not work. So you give the nanocrystalline silver in a controlled release mode, and so you have something
Mepilex AG.
some specific dressings for that. Okay, so you use any of those
We can
things.
use an installation
NPWT, antibiotic installing.
Okay, we'll come to that later on. Madam, here I want to complete means you have to use, you can use either hydrocolloids or alginates, calcium alginates, or you have polyurethane foam impregnated with silver. So these are all very, very specific dressings for biofilm. All right. So when you put it in, you leave it for a few days. You need not do a daily change of dressings. When you remove it, the biofilm usually comes off with that dressing. So that is how, madam.
And how much marks should be given? Because
I
team
think
B did
both of
not
them,
did not tell
gave
about
only
the
very partial answers. So I think team B will get marks, and team A for starting enzymatic debridement. So I think
So
one.
one.
Yeah.
Okay.
Sorry to interrupt.
Yeah.
Time
Is over.
yeah. If you have any last question, you can answer. You can ask one more.
Last question is only one thing. What in this patient, old refractory wound, are there any specific dressings that you can employ so that you get healing in this patient? Can you tell me that? The question now will be to team A. In this refractory wound, all your normal things is not going to heal. The patient is going to go down because it is 3 months old raw area.
First, I'd start with the enzymatic or autolytic debridement. And
So
as the scar loosens up, we'll debride it and then try to put a negative pressure wound therapy to heal it faster.
Okay.
And then we'll go for grafting.
Anything else? Any other recent advances do you know in dressings? What are the dressings that are available, which are tried, which are regenerative?
Hydrocolloid alginate dressings which will absorb the...
No. Team B?
Can you pass it on to team B?
Team B?
Ma'am, use of Mepilex AG dressings.
Okay.
Aquacell AG or Mepilex AG dressings.
Fine, and they are all right, but then how are they going to anyway promote angiogenesis or regeneration? What I want to know is whether you have heard of any regenerative modality.
Yes.
Have you heard of stem cells? Have you heard of PRPs and all those things in burn
Yes.
bones? Yes? Okay. So when
Ma'am,
you use any of them
PRP,
in
or
this,
we can use fat cells, autolytic.
PRF, platelet-rich fibrin matrix, and APRP.
PRPs.
Do you have any idea
And
how to make the
SPF.
PRP?
Yes, ma'am.
Yes, ma'am.
Ma'am, either we can inject or either we can spray PRP. We'll take blood from the patient and
heparinase blood we'll take and we'll put it in the centrifuge
for 10 minutes at 3000 RPM.
RPMs.
Then we'll get 3 layers. Lower will be the blood components, that is the RBC, then the buffy coat, and then the platelet or the plasma. Then we'll take that plasma and we'll
again centrifuge over 3000 RPM again for 10 minutes. And then we'll get 2 layers of platelet poor and platelet rich plasma.
So the lower one, which has the platelet rich
one, we'll use it for the wound region.
No, we'll use platelet rich, we'll use platelet we'll use both, because
yes,
even the leukocytes have a lot of granulation. So in this patient, actually, that only was used. The stem cells and PRP was used. And then you can see the result. I think we'll have to stop with that now, because
One question to Team B, ma'am. Last question to Team B, and we'll.
Oh, last question to Team B. Okay, then
one-
let it be a very specific question. You have heard of BioBrain and Integra, I think. Have you heard, Team B?
Yes, ma'am.
Okay. What is the difference between the two?
Ma'am, BioBrain basically contains the porcine collagen, whereas Integra contains the bovine collagen. The main difference.
So you can use both for all wounds? Okay. Team A?
BioBrain has got a nylon component. Not everything is biological. It has got a nylon component in BioBrain. Both are bilayered skin substitutes with a silicone layer on top, and BioBrain has got underneath the silicone, it has got a nylon impregnated dermal substitute from the bovine or porcine collagen.
But in Integra, there is one silicone sheet, and underneath there is collagen fiber.
Collagen with glycosaminoglycans.
From the shark.
So in there, you know the
Converting
difference. Can you now tell me the difference? Where can you use BioBrain? Where can you use Integra?
Integra is
it has dermal
permanent thing, ma'am. We can use it as a substitute for dermis, whereas BioBrain is not a. It is a temporary.
So BioBrain can be used only in second degree partial thickness burns, because it is only a temporary cover.
Yes.
Has some collagen, there is some regeneration, but ultimately you will have, it will peel off and you will have to graft. Integra can be used in full thickness burns. So that is the only difference. BioBrain and Integra, the difference. Okay. Integra can be used in full thickness burns. You can put it in, leave it for 3 weeks, and then it will nicely produce a dermis over which you can give a small, thin SSG, right? So this is the difference. So I think Team A will get the marks for this, madam.
Oh, carry on, mark. Okay, passed on, mark. Okay.
Thank you,
Right,
ma'am.
madam. I'm done.
Now I would like to request Smita, ma'am, to ask any questions to the Team A and Team B.
Yeah, okay. Yeah, Team A, quickly, since we don't have time, just diagnose this picture, please.
It is an old infected burns involving the gluteal region, bilateral gluteal region and bilateral thighs with areas of eschar.
Caused due to thermal burns?
Thermal burns, old infected thermal burns.
So you agree that there are burns of different grades in this?
Indeterminate thickness.
Yeah, so indeterminate thickness, and if the patient had come to you in the first stage, like early, how would you diagnose the different degrees of burns other than your physical examination? What are the other kind of scoring systems you could have done to forget the scoring system? Tell us how you can diagnose the depth of the burns. What are the methods in diagnosing
You can
depth of the
diagnose it using vital dyes like methylene blue. and biopsy of the tissue can be taken, or ICG injection can be done, or laser flow Doppler we can check, and thermography also can be used.
That is either you can do medical or surgical methods,
Yes,
right?
Yes.
So I
in
give the
medical-
marks to team A, madam.
Yeah. So can anybody tell me what is FLIR?
So now the question is to team B, madam.
Okay, B. Yeah, okay, team B.
Ma'am, can you repeat the question, please?
What is FLIR? FLIR. It is continuous to the question that I asked them, asked the team A.
Fluorescent light, infrared. Ma'am, it is used to assess the burn depth only.
And
It is
difference between viable and non-viable tissue using a fluorescent dye infrared
spectroscopy.
Yeah, it's called forward-looking infrared technology. And FLIR 1, what, can you tell me what FLIR 1 is?
No idea.
That's a smartphone compatible thermal imaging camera to assess the depth of the burn. All right. Now,
Can I give the marks to them, madam? Can I give the marks?
Yeah, I guess so. They knew what it was.
Okay.
And for team A, why is this kind of a burn that you're seeing in the picture a challenge? What are the challenges?
One thing is the general condition of patient. She's a 60-year-old female.
Okay.
The comorbid status is yet to be inquired. So simultaneously taking care of the general condition, we have to.
Okay, all right. Now to locally, what is the challenge?
The position, the area where it has occurred, the burns, the region of the burns is a
challenge.
challenge.
Chances of infection with atypical bacteria are like
Contamination risk.
Contamination is high.
And
that is a challenge. And positioning of the patient after every surgery and splint, providing a splint and all is also.
So what would you term it as? A shear stress. Once you are doing a dressing after a graft, the shear stress of the positioning and all that shear and the contamination risk are the main local challenges once you treat it. Like, whatever treatment Dr. Neela has already discussed all the options of treatment, and also I won't repeat that.
So team A gets the mark, madam.
Yeah.
Okay, now the question to team B. Team B. Question to
One
team
more
B,
question,
madam.
ma'am, to team B.
One of it. Okay, this is if the patient had come to you from a village or something after 1 or 2 weeks and you've admitted the patient and you see mild tremors when you go for rounds, what are the causes of that? It's a male, female, whatever patient, they've come after 2 weeks. So mild tremors in the hands and because this, Dr. Neela had discussed this earlier, so I'm asking a question on based of that.
The patient might be going into sepsis, ma'am.
Okay, one of the reason is sepsis and?
Dyselectrolytemia.
Yeah, electrolyte disturbance and?
Ma'am, hypovolemia, so that the patient is having shivers to preserve the body temperature.
No, shivers and tremors are totally you can really differentiate between the both of them.
It might be due to micronutrient deficiencies also, ma'am. Vitamin B12 deficiencies might give rise to tremors.
Yeah, some minerals deficiency.
Minerals or micronutrients.
Anything else? Alcohol withdrawal?
Alcohol withdrawal, yes, ma'am.
Okay, we see a lot of people withdrawal and alcohol. All right.
Can I give the marks to them, madam?
Yes.
Okay, ma'am. Thank you, ma'am.
Are we done?
Now I'd like to request Srivastav sir and Sanjeev Uppal sir.
Dr. Sanjeev is here. Dr. Sanjeev is here.
I hope, sir. I'm not sure.
Okay. So I can ask the question.
Yes, sir. Yes, sir.
First thing, very basic. It is written that it is an infected, neglected burn wound. Why not it should be called as chronic burn? What are the difference between neglected burn and chronic burn? Team A, I should ask first.
Yes, sir. Yes, sir.
So chronic burn is when we are treating it and it
Treating
has
and
not
the
got healed.
sequences of the consequences of already we have treated.
This is also being treated.
The timely, accurate management was not done in this. What is to be done?
So what is the difference in
Okay.
appearance of a chronic burn and this type of burn?
Chronic burn would be healed wounds, but with
Malnutrition or other
other consequences. This is a non-healing.
Team B.
So chronic burn basically will have a chronic granulation tissue. So the underlying tissue will be fibrotic, and the overlying to which will be the granulation tissue. Underlying tissue will be fibrotic in nature.
To some extent, you are right. It might or might not be infected.
Yeah,
but there will be amount of fibrosis and some granulation tissue, some healing areas. So that will be the chronic wound. So
it
to
passes
team B,
on.
the mark should go.
Passed on mark to team B. So one more question to
One
team
more
B,
question
sir.
to team B, sir.
I am going to ask. What are the chances of fungal infection in this wound?
With increasing antibiotic resistance, we are now witnessing increase in fungal infection nowadays.
I'm not asking theory. In this patient, what are the chances of fungal infection?
So I could see there are some areas which is looking yellow, waxy in color, which might lead onto fungal infection with Candida or Aspergillus.
Okay, anything team A?
That she's a 60-year-old female with comorbidities. She'll be immunosuppressed, so there will be high chances of fungal infection.
Yes. So 1 mark to each. Another
Okay.
question. How will you do that definitive investigation for assessing the fungal infection?
Team A. Team A. Team A.
Tissue
Yes.
cultures, potassium hydroxide suspension. We check for the culture of the KOH.
Culture of the KOH?
KOH mold, we'll check the
team B.
So we can go for KOH mount, or we can also go for we can send the tissue to look for fungal elements. Microscopic examination, basically.
How will you send? How will you send? What should be the procedure to send it?
So
you
the
will
suspicious
take just swab or scrap?
Tissues.
So we can send a tissue biopsy of the suspicious area.
At least how many places?
So 4 to 5.
Okay, it is 6. Okay.
Sir, do they get
Depending
any
on
mark?
1 mark to team B.
Okay, sir.
One more question.
And one more question I can
Question
ask
to
team
to
2.
team B.
Yes.
Team B. Yes, sir.
Yes, team B. You were discussing that thickness of SSG. How can you assess on table? Will you use screw gauge or vernier caliper? You said 0.3, 0.4 something. It is not 0.3, 0.4. It is 0.0 something.
030.
Okay? But how will you assess on the table?
Sir,
You are
by
not
looking-
going to take that, I think, or you do it.
Sir, one is by looking at the dermal components and also looking whether it is transparent or translucent based on how it looks. And also
If it
on
is translucent,
sir, if it is transparent, it's a very thin graft. If there's some amount of translucency is there, the thickness increases as the
it will be transparent.
So for thin graft, it will be transparent. For thick STSG, it will be
It
translucent.
will always be translucent. Degree may differ. Okay. So anything team A to add?
Sir, the graft will roll on itself, sir, if it is very thick.
And also
graft
when we use-
rolls, how much thickness is there if that graft rolls?
Thick STSG, sir, 0.018
or something
to
else?
elastin component is higher, it will.
Primary.
And sir, we'll also check the donor bed.
Donor bed also, the punctate bleeding we have to check, sir.
If we are
You
able
have to see the dermal component while taking the graft and observing the translucency or thickness of the graft. So both things you have to see, the donor area, the punctate bleeding, or the dermal component up to reticular dermis, and only full thickness graft will roll altogether.
Sir, how
Okay,
much
I
marks
think
do
time
I
is
give?
over.
Yes, sir.
1 marks to each.
Okay, sir.
I would like to request Bhattacharya sir to ask any questions.
Yeah, I will continue with Dr. Srivastav. You said graph rolls. Why it rolls?
Due to the elastin component in the dermis.
Due to the?
Elastin
Where is elastin?
in the dermis. In the
That answers this question.
reticular dermis, sir.
In the
Particularly the reticular dermis.
So it is the collagen fibers and elastic fibers. Where are they? Where are they?
in the reticular
Reticular dermis.
Okay. So which graft will roll more?
Thicker graft.
Full thickness
full
graft
thickness
will
graft will
roll.
roll.
Exactly.
Yes,
You can see it always
Yes,
when
sir.
once you take it.
Yes.
Now my
So-
next question is
So team A gets the full marks, sir?
one.
One
They
mark.
guessed.
Okay.
They rather guessed.
Okay. Okay, sir. Okay.
Okay.
Now the question to team B.
In B, we have talked a lot about the assessment of devitalized tissue in burn. And one more technique is there, which is simple intraoperative. And what is that?
Methylene blue.
No,
So
that is
can
one.
I-
You have
can I
already
answer?
mentioned. Any other? Yes,
Indocyanine green.
you have mentioned. Any other? Other
Color
than
flow
whatever you have
Doppler,
mentioned.
laser flowmetry.
More simpler.
Can I answer?
Yes, please.
Fluorescent dye techniques.
Fluorescent dye. Okay. So through which route the dye is given?
IV, sir, or the previous.
Dose. IV is correct. You guessed, but it is correct. Dose.
Dose side.
Okay. So what is the advantage of fluorescent technique? What is the equipment and surrounding you require?
Dark, and we need a UV light cameras.
UV light is one, and surrounding should be
Dark.
dark. Now, what is the advantage of fluorescent over other techniques which you have just mentioned?
They're cumbersome and more expensive.
Easily
more expensive.
This is easily.
Advantage of fluorescent.
It is easily available. It is not that
Inexpensive.
costly, and it will go to the tissue at the same time. Like the response is very fast.
So, under ultraviolet lamp, what will you see? How will you decide this area is devitalized and this area is viable?
If it
Or
turns
this plane is
green-
devitalized, this plane is viable?
If it turns green, it is whiter, sir. And if
No, how will it look? Suppose it is devitalized some area. How will it look?
There won't be any color fluorescence.
There won't be. It won't take color, sir.
Violet,
B?
green.
Team B.
So the devitalized tissue will appear more dark in compared to the vitalized tissue.
And vitalized will look like what?
Sir,
It
it
will,
will
it
light
will
up
look
fluorescence.
pale. It will appear lighter than the devitalized tissues.
Oh, that's a relative term you are telling. Darker, lighter. I'm asking color.
Sir, pale yellow or lightish, it will light up under the fluorescent light.
Pale yellow color.
Yes, it is yellowish is the viable part. Okay. And dark is the.
Devitalized.
Now, what is the advantage of this over other techniques which you have mentioned?
Less toxic, it will be less toxic.
Toxicity is tested before injecting the dye. Otherwise, it is not toxic. How the, yeah,
Shorter
other team?
half-life, sir.
Team A?
Sir,
A shorter half-life.
not immediately, sir, in seconds, like less than a minute.
How long you can see this dye to be present in the tissue? That is the advantage of over other techniques.
Half-life is 30 to 45 minutes.
The half-life of the
is what?
30
Sir,
to
it will
45
stay
minutes
till
half-life.
30 minutes so that we can assess our debridement.
Or 30 minutes.
30 minutes, yes.
30, huh?
Yes, sir, 30 minutes.
30 minutes is wrong. How the dye is excreted from the body? That is the answer.
Renal excretion.
Renal excretion in 90 minutes is the half-life.
Renal excretion is the correct answer. 90 minutes is wrong. It is excreted through kidney after 36 hours. So the advantage is that you can take the part under the ultraviolet lamp anytime within 36 hours repeatedly. Whether it is a burn or a flap or any other tissue. So that is the greatest advantage. It is cheap, easy to conduct, and up to 36 hours you can keep on visualizing its progress. So suppose you have debrided and again you see the ultraviolet lamp, again you see that some dark area, again you can debride. So that is the greatest advantage.
So what is the mark that we give, sir?
1-1. I think both of them have answered partly.
Partly, okay.
Okay,
Thank
sir.
you.
Thank you, sir. Now I'd like to move.
Rohit, can I have a question?
Yes, sir. Yes, sir. Sure, sir. Definitely.
There is a clarification. I responded to that the maximum of abduction can be done on an elbow on table should be the overcorrection. So that is 180. But when you plaster it, you have to be less than that. In considering the vascularity, as already mentioned by Professor Lakshmi. And my question to the team A is, in this particular case, we are seeing clinically on the photograph. Suppose there is a deeper infection, what other structures can be affected? And you can think about it and you go for an investigation.
So we should think about osteomyelitis, deeper bone infections.
Which bone?
The one which are more subcutaneous. The
Which bone?
ischium.
Which bone?
Greater trochanter.
Greater trochanter ischium.
Greater trochanter. If you see in the left side in the gluteal region,
Yes, sir.
is there greater trochanter or
Ischium.
some other bone?
Ischial tuberosity, sir. Ischial tuberosity.
Okay, you are correcting itself. Then how do you know there is an infection there?
There will be deep-seated collections, sir. The
So I
systemic.
told you my second part of question. What is the investigation you have to go
That goes,
for?
sir, that goes to team B.
Yeah. Team
Okay.
B.
Please repeat the question, sir.
Yeah. My question was, if in this case there is a deeper tissue involvement and already told about there is an infection of the
Yes.
bone, what
Yes.
investigation should you go?
So for initial investigation, we would like to go for the X-ray of the X-ray of the pelvic region, pelvic and the leg bones, to look for osteomyelitic changes, the sunburst appearance.
And even MRI can help us diagnose early osteomyelitic changes.
The best
Okay.
investigation would be the MRI of the.
Okay, I think you don't get the full marks. You
Best
have to see the
investigation.
periosteal reaction
Periosteal
of
reaction,
the
sunburst
bone.
appearance.
Okay, and there will be synovitis. There will be a synovial. There will be a so-called bursitis around the bone also.
Yes.
So that can be made out. Okay. So the answer is half. I think you get both the teams, they get half marks each. Second of my question is, what is a primary contraction of a split thickness skin graft? And secondary contracture and a tertiary contracture of split thickness skin grafts. It is
So-
one question.
So
Team one.
Primary contracture is due to the elastin content in the dermis, which occurs when the
table.
graft is taken. Secondary contracture is basically a feature of the wound bed and the myofibroblasts in the wound bed, which leads to secondary contracture of the.
And thin grafts have more of secondary contracture.
And tertiary contracture is when it gives any functional limitation in the future, causing contractures.
Okay, I think you get the full mark for it.
Now that
So,
question to team B, sir. Now
yeah,
question
a
to team B.
Suppose there is an infection of the ischium and there is a bursitis. How do you handle it, or how do you manage it?
So we would like to go for the debridement of the wound, and then we'll assess for the defect and plan for the flap coverage for the same.
You don't do you don't address about the infection of the bone and also the bursa.
So we if we can see any osteomyelitic changes, then we have to start the patient on long-term antibiotics at least for 6 weeks. 6-week therapy.
Those things I'm not in. Locally, how will you address about the osteomyelitic ischial bone?
So we would like to go for the debridement and to excise the pseudo bursa if it's forming, and to do the debridement of the osteomyelitic bone also.
Okay, you have told, I think you get half mark only. Now you're doing the answer, but you have to do a bursectomy and you have to do a osteomyelitic curettage of the bone and excision of the dead bone. Okay? Thank you very much.
Thank you.
Done.
Now we'll move to the questions from other PG teams. We have only 2 teams left. Now questions from BMCRI. Do you have any questions to team A?
Yes, like, assuming that this wound infection is controlled, what are your skin cover options?
We'll go for split thickness skin graft for this.
After debridement, when the wound bed is ready.
Since the donor area is less, like what are your options?
We can take it from the legs or we can take it from the back, because from the back it will be easier because the patient will be already prone while.
Or lateral position. And otherwise we can go for allograft as an interim.
Any other options?
The acellular dermal matrix we can use like Integra or BTM.
Anything else?
Cultured keratinocytes.
Okay, sir. Also, meek micrografting can be added.
Meek. Mesh.
It's correct, sir.
Yes. Expanded grafts.
Now, question from KEM Mumbai, Team 11. You have any questions to Team B?
How long will you wait to?
You are not audible, actually.
And what is the mechanism of it? Hello?
Hello, yeah. Can you repeat
Can
the
you be
question?
more clear?
Hello? Yeah. After applying methylene blue dye, after how long will you wait to assess the depth of the burn, and what is the mechanism?
Team B.
Team B. Team B.
Methylene blue spreads via viable lymphatics, and after applying a methylene blue, we wait for about 15 to 30 minutes before going for the next session.
Rishikesh?
Is the answer right?
No, sir.
Then we can ask
No,
Team
ma'am.
Team A can answer. Just wait.
Sir, we'll put the methylene blue 12 hours prior to taking patient for surgery. In 12 hours it will take, and then we'll come to know the viable and non-viable regions. And it will stay for some 1 day to 1.5 days, 36 hours. Till we'll remove the areas which are stained by the methylene blue. And till the methylene blue is out.
The viable one will be whitish leuco.
The area which has not taken the stain will be viable, and the one which has taken is non-viable. So we'll remove the non-viable one.
Done.
Yes, that's correct. Yes, sir, that's correct, sir.
Team A gets the marks.
1 mark. Carry over question. So 1
Yes,
mark.
exactly.
Okay.
Team A has to explain properly.
Yes.
What is taken up, or taken up is something is
Taken
going
up is
happened. What will happen?
taken
Why
up
it
is
is becoming
non-viable.
white?
Right.
Pardon?
Because it will get cleared, ma'am. That methylene blue will get cleared from the viable tissue,
We call
but
it
it will,
leucopigmentation. Whitish.
but it will stay in the non-viable part because it does not have
It gets
lymphatic tube.
oxidized by the oxygen in the viable tissue.
Yes, that is correct. It is metabolized in the viable tissue and gets converted into leucomethylene.
Leucomethylene.
Okay.
Yes.
In where the cells, it is not metabolized, it is strained part.
Yes.
Okay. You will get mark, but you should explain in proper way.
Okay, ma'am. Now we'll move to the post-op results. In the meantime, ma'am, you'd like to
Yeah, you showed Rohit. This is the first spotter treated at St. John's Medical College by Dr. Sundar sir. The Sundara sir, would you like to explain?
Yes, madam. So this is showing the episiotomy. Are there further pictures also, madam?
Yeah, we are having.
Yeah,
Sir,
so
which day what you was done, you please explain in a systematic way.
I don't exactly remember for this patient,
No,
but
no, approximate time you can tell.
so this would have been an presentation.
On the day of presentation, you have done the eschorotomy, no fasciotomy.
No, this is down to the muscle, madam. So this would be a fasciotomy.
Fasciotomy, right. So all compartments released.
Yeah, yeah. So midlateral on both the upper limbs, I mean lower limbs. And the next picture is showing after the patient has been stabilized. This is epiphyseal excision or burn wound excision, which is done. And then
On 8th day, sir, something approximate 1 week.
no, madam. In the later part of the first week, when the patient is stabilized, before the
Okay.
infection sets in. As soon as blood is arranged, patient is stabilized. So this is after covering with cadaver skin, allograft. So the lower part of the leg where it is deep partial thickness has undergone tangential excision. Only the full thickness burn has been treated with epiphyseal excision or burn wound excision.
So how much blood was given to this patient, sir, when you have done this excision?
So it is the blood requirement is lesser than with tangential excision. With tangential excision,
Hello?
Hello, sir. Hello, sir.
Hello?
I think
Not audible.
sir is not audible, ma'am.
Then got
Oh.
I think he has been disconnected.
No, sir.
His internet might be having problem.
He has some issues with internet, I think, sir. Ma'am, just please, I will go through the slides, ma'am.
Yeah. I think you can go for the second spotter and third.
Second
Once Sar joins, he will tell.
Okay, ma'am.
This is the second spotter post-op results. Dr. Sanjeev Giri will explain the thing. It is done by him.
Hello. Yes. Madam, this is actually a recontracture case. So we have given the TDAP flap there. Must have seen thoracodorsal artery perforator flap. This is first we have operated, I think, 1.5 years back, but patient doesn't maintain the splint and again come back to us with this recurrent contracture, and we have given this TDAP flap, thoracodorsal artery perforator flap, must have seen, and it has very nicely settled under the dome, and patient is able to now abduct and do everything, and doesn't require any splinters, although we have kept some time for the 3 to 6 weeks. But now the patient is doing good.
Yes, sir. Thank you, sir.
Thank you.
Next, this is the second case, ma'am.
This is done at our place only. The patient was mentally retarded. So we have done the 5 flap jet plastic. So you can see the flap nicely sitting in the axillary thing, and even the precautions were taken not to have the acute angulations, and advanced the adjacent skin, and healed well, and abduction is good. With physiotherapy, the remaining abduction also he will get back. So this is the post-op result. Okay.
Next, third spotter, ma'am. I think Neela, ma'am.
Dr. Neela is available. She has treated this case. Dr. Neela.
Yeah, there is a previous collage, madam. Have you said it? Is it possible to see that?
Previous slide.
There is one more collage which I had sent in the healing phase. Is it there?
Okay. Meanwhile, we'll take the feedback. I'll send the photos to Rohit. He will display. Okay.
Okay. Okay.
Dr. Umar, invite Dr. Umar to take the feedbacks, Rohit.
I would like to invite Dr. Umar, sir. Just take feedback from the faculty and the PGs and our patrons.
Hello, good evening all.
Good evening.
The feedback. First of all, I invite today's panelists for the feedback. We will start with Dr. Sundar Raj, if he's online this time. Dr. Sundar?
Yeah, sorry.
Let's go to Dr. Sanjay. Sanjay?
Yeah. Hello.
Now, please give feedback about the Plastiquest and this Plastiquest challenge.
Yeah. Actually, both the teams have done well. They have answered all the questions, I think. And about the clinical examination, some parts they have missed out. Like as sir pointed out, they should tell about the scars. What is the scar position and how the scars were at the present. Those things they have missed out. Otherwise, they have answered well.
Thank you.
Thank you.
Dr. Neela. Neela, ma'am.
Ma'am, we are ready with the.
Yeah, please. Can you show me then the first thing?
Sure, ma'am. Sure.
Yeah, so in this patient, there were 3 important things. One is we had to deal with the infection. 2, we had to deal with her nutrition also, because that was very bad when she came. And third, the local dressing. So in the local dressings, apart from debridement, we usually use thin foam absorbable dressings with silver impregnated. And in this patient, we had to use, because the granulation was so pale and she was generally so compromised, we used PRP, and we were able to get mesenchymal stem cells. So we're part of a study. We were able to get that, and we used that. Now, if you see the healing, that's why it is a little something. You can see islets of epithelial cells forming inside the burn bone. So that was something which was which happened because of the PRP and the stem cell therapy. Of course, we use even human epidermal growth factor for all these patients. And then the next area, we have to debridement. Next picture, please. Yeah. So in this case, the graft, after the wound was optimized, the graft was taken from the back and the legs, like what somebody said, some team A, I think they said that. So the black and the posterior aspect of the legs, and then she was grafted. The graft take was pretty okay, and we were able to discharge her in 2 weeks' time with pressure dressings. So this was the follow-up.
Thank you, ma'am. Thank you so much.
Dr. Neela, did you need any diversion?
No, madam.
Okay.
I didn't do any diversion. So, yeah, this was through, the most important thing is nutrition. I said we had to put her on low residue diet. We were not able to talk on all those things today. So that we were able to sort of manage the fecal soiling that is inevitable in these cases.
Okay.
Processing. How was the processing done to get these answers?
Excuse me, somebody is not audible.
Omar sir, ma'am, I think he has some flashy network.
Hello?
Ma'am, just give your feedback on this session.
My feedback, yes, both the teams were very good. They were able to answer all the basics questions very nicely. I think recent advances in burns is a topic which they should brush up a little, which seems to be an issue in both teams. Otherwise, general questions, the basics, they seem to be quite well versed in, and that is quite good.
Madam, give your feedback about the Plastiquest Challenge program.
The program also is great, madam. It is something which will be of so much immense use to the postgraduates, and it is a learning experience for all concerned, not only the postgraduates, even the other doctors joining in, the consultants, to learn from the greats of plastic surgery in the country all around. So it is a great endeavor, and I must really thank you for taking this up.
Thank you, ma'am.
Are you hearing me? Am I audible?
Sir, I think your voice is not clear. It is like we are
You
getting
can
a lot of
ask
rumblings in your voice. Rumble is there's a lot of rumble.
Devi to continue, or you can continue.
Okay, ma'am. Hello.
Rohit, you
Hello, ma'am.
continue.
Okay, ma'am, I will continue. I would like to request our third panelist, Dr. Sundarraj sir, to just give your feedback and about Plastiquest and comments on this session, sir.
Other panelists have said this is very useful for the students. They get to get it in one place, so many examiners and so many exam questions all in one place. Our students who have passed out have been really thankful having attended these sessions in preparation for their exams. So it's an excellent effort by all of you.
Thank you so much.
Thank you, sir. Can you continue that spotters? Follow-up of the spotters, sir.
Yeah, I lost the internet connection.
Now you can tell, sir.
Yes, madam.
1 minute, sir. Give me a second,
You
sir.
can show the photos.
Yes, ma'am. I'm doing that.
Dr. Lakshmi, in the meantime, can I suggest something?
Yeah, please,
No,
Smita.
it's such a lovely platform for not only PGs, for us to learn also. That's everybody said. But do you think somebody can formulate all these questions and answers and all about burns? You've done it in different subspecialties of plastic surgery. So you bring it out on the form of a book or on the net or something, all the questions that everybody's asked and answers and all that. That will be very helpful for the newer PGs who are coming and all that.
Yes, Smita, I already announced all these questions, what we are asking. We are making a soft booklet which will be distributed to all the delegates at APBC. As
Yeah, I know
we
you.
are, yeah.
But it should be like online also, Lakshmi, for people who
Yeah,
don't.
we will upload in Plastiquest Challenge.
Yeah.
The booklet will be there. At the same time, they can watch the video corresponding burn spotters.
Yeah, that will be very helpful for a lot of people. Yes,
Already
right.
first session is uploaded in the PC channel. So this booklet we will compile totally along with these questions for each spotter and compile and will upload. I'll definitely share the link for all of you.
Madam,
Yes,
it will
please.
be one day Guinness Book of World Records.
Sir,
such
it's
thing
the
has started.
contribution of faculty of Pan India. So
I am telling you, know, Guinness Book of World Record, one time it will go. Because such thing has never happened anywhere in the world.
we'll do many things, sir, when we determine. And the panelists and moderators, the faculty are excellently responding. We are taking their feedback and making our sessions better and better useful for the PGs. So the not only PGs, faculty also putting lot of effort to compile these, especially these case series. So senior most people also giving a lot of finer refinements of our sessions. We are including time to time.
Ma'am, can we proceed with
Sundar sir.
what Sundaraj?
Yeah.
Sir, this is like
we were here, I think, yeah.
yes, sir, yes. Tangential excision of the
covered with allograft. The thigh is bone wound excision or epiphyseal excision, and leg and dorsum of the foot is tangential excision. Question often in the mind is why can't we do autografting straight away? Because it looks healthy. What the allograft does is if the allograft takes, then it is an indicator that the bacterial load as well as the whether the wound bed can support nutrition vascularity to the autograft is known, as can be seen in the next photograph. So here you can see
One more point I would like to ask, as Dr. Bhattacharya sir pointed out, have you removed the skin over the knee joint also, sir?
Yeah.
Everything is removed, yeah. And the leg part is covered with the auto and the thigh with the allograft, sir?
No, the whole thing is allo.
Allo only, okay.
Yeah. So the point I was making is there is good take of the allo, and it declares that the bed is good vascularity to support, and also that the bacterial load is also not there. That is the usefulness of the allo. And
This is after how many days of allograft?
maybe about a week, 8 days, madam.
In between, did you do the dressing, sir?
Yeah. So we would do once in 2 days the dressing.
Okay, right.
And then we can see some autograft harvest done from the left leg.
So you removed the entire allograft on 10th day?
Yeah, it is separated and well granulated bed is there. Sometimes we like an area like this, which is a full thickness, where you are for sure know that there is not going to be any healing under that. You can go in early and you can create windows 5 by 5 areas, peel off the allo and put the auto on those areas also. And in a staged manner, the deep areas have been covered with autograft.
So meshed autograft was placed, patches?
Also stamps, large stamps.
Okay.
Yeah.
Thank you, sir. Thank you,
So
sir.
the autograft was harvested from the leftover skin on the leg and the back, sir?
Yeah. Yes, ma'am.
Okay. Very nice results, sir.
Yeah,
Thank you.
actually, photos belongs to my colleague, Dr. Naren. We all work
Very
together as a team.
wonderfully treated.
Yeah.
I think the hospital's stay might be 3 weeks or 1 month.